Hello and welcome everybody from our CCI family and beyond for this wonderful webinar on this interesting topic, which is going to be medication mayhem, the drugs which are contraindicated in obstructive airway disease. I think most of our webinars are talking on SITT and what is indicated and what is the best and what not. But today, I think we are going the other way around and looking at what is not right in the context of obstructive airway disease or what may be a little avoidable in the context of a obstructive airway disease. With that, we have a wonderful panel with us, and I'll first make sure that I introduce the first two speakers. I think the first opening batsman is going to be Dr. Jyoti Bajpai from Lucknow, and she's going to give her talk first. I won't disclose you what she's going to talk about because let us keep that as an interesting feature. Because this is a fairly, I wouldn't say absolutely everything is contraindicated or absolutely 100% contraindicated. There are always relative contraindications and ways to go around whatever it is. So, Dr. Jyoti, welcome to this from Lucknow. Welcome to this webinar. And then that will be followed by Dr. Prajay Lunia's talks from Mumbai. He's a king of the western suburbs in Mumbai, and I think he must be very popular in that area. So, welcome, Dr. Prajay, and he will be talking on some other concepts, some other drugs. Let me keep that as a little bit of a secret because it will be disclosed in the next half a minute. So, and then of course, we have as the panelist, I'll introduce the other two panelists eventually. So once that gets over. So over to Dr. Jyoti for your first presentation, and let's have a wonderful discussion. Thank you.
Hello friends, good evening to all. Thank you Dr. Nitin sir for inviting me to deliver a talk on drugs which are contraindicated in obstructive airway diseases in special reference to beta blockers, myth and reality. I would also like to thank Dr. N.H. Krishna sir, Ravi Doshi sir, Atri sir, Anil Maske sir and Dr. Ashish sir for giving opportunity to speak on this very prestigious platform, Chess Council of India. So this is my disclosure. Beta receptors. There are three kinds of beta receptors, beta 1, beta 2 and beta 3. Beta 1 mainly found in heart and kidneys. Beta 2 mainly found in smooth muscles, lungs, blood vessels, GI tract, bladder, uterus and liver. And beta 3 mainly found in adipose tissue. Main function of beta 2 receptor is smooth muscle relaxation and vasodilation. And main function of beta 1 receptor are increase the heart rate, contractility. The most important, beta blocker remain the drug of the first choice in recommendation from the respective medical societies for heart failure, coronary artery disease and atrial fibrillation, as well as in hypertension complicated with heart failure, angina pectoris or prior MI. So beta blocker is an important or main cornerstone drug for heart failure and CAD patients. So there is a great tussle in between pulmonologists and cardiologists in related to beta blocker uses. Pulmonologists think that beta blocker induce bronchoconstriction in COPD patient, but as per the cardiologist point of view, beta blockers are the very important drugs in their armamentarium. Major concern about the use of beta blocker in OAD is bronchoconstriction. They might exacerbate the disease process. Cardiovascular disease and COPD have a common risk factors like angina, tobacco, smoking, and pollution. There is a prevalence of systolic and diastolic heart failure is about 20 to 70% in patients of COPD, and annual incidence of heart failure is about 3 to 4% in COPD patients. 40% of the COPD patients who are on mechanical ventilation had a left ventricular dysfunction, and hospital readmission due to acute exacerbation of COPD is linked to 4 times higher risk of mortality, 2 times higher risk of myocardial infarction, and 6-fold higher risk of heart failure. So, cardiovascular disease and COPD share the common risk factors and occur in 30% of the cases. Unfortunately, there are diagnostic and therapeutic problems related to the underdiagnosis of COPD or vice versa, underdiagnosis of CAD in COPD, and the underuse of beta blockers. This is about classification of the beta blockers. There are two kinds of beta blockers, non-selective beta blockers and beta 1 selective beta blockers. And they have specific properties like intrinsic sympathomimetic activity and hydrophilic and lipophilic nature. And there is additional alpha blocking activity. So beta 1 selective beta blockers mainly act on beta 1 receptors like atenolol, bisoprolol, betoxolol, esmolol, nebivolol. And the other beta blockers, non-selective beta blockers, most commonly used are propranolol and carvedilol. So all beta blockers are not the same because of their properties like beta selectivity, intrinsic sympathomimetic activity, and lipid solubility and vasodilatory property. There another classification regarding the generation. First generation beta blockers, they are non-selective beta blockers, both beta 1 and beta 2, like propanol. Second generation beta blockers, they are highly selective beta blockers. They act on blocking the beta 1 receptors like atenolol, metoprolol, bisoprolol. And the third generation and newer generation beta blockers are carvedilol and nebivolol. Carvedilol mainly acts blocking the beta 1 and beta 2 and also acts on alpha receptor also. So this is a slide regarding the use of various beta blockers and their affinity to beta receptors. So among all the beta blockers, bisoprolol and nebivolol have a higher cardioselectivity, about 19 to 20 times higher than other beta blockers for beta 1 receptors. So what are the advantages of cardioselective beta blockers over non-selective beta blockers? Like the cardioselective beta blockers are safer in asthmatic, safer in diabetes, peripheral vascular disease, less deleterious effect on lipid profile, less liable to impair exercise capacity. This is a recent meta-analysis in 2021, use of beta blockers in asthma, in which non-selective beta blockers had a higher risk of exacerbation about 5 to 12 fold. And cardioselective beta blockers, bisoprolol, metoprolol, appear to be safer, and low dose initiation with gradual increase is recommended to avoid the adverse effect. So non-selective beta blockers should be avoided in bronchial asthma patients like propanol, sotalol, and timolol. Beta blockers eye drop, also non-selective beta blocker eye drops should be avoided in asthmatic patient. Most commonly, cardioselective beta blocker, bisoprolol and nebivolol are indicated in asthmatic patients if there is no absolute contraindication, but the relative risk benefit should be considered. GINA also recommends regarding the use of beta blocker. Usually they should be avoided, but if in conditions like heart failure or myocardial infarction, a cardioselective beta blocker should be selected and initiated low dose by a specialist. Now coming to the beta blockers used in COPD. It depends on the severity of the COPD, type of beta blockers, dose of beta blockers, and underlying cardiac disease. So most of the non-randomized observational studies showed that beta blockers benefit patients with COPD and coexisting cardiovascular diseases. They reduce the risk of exacerbation, death, regardless of presence of cardiac diseases. Another meta-analysis regarding the use of beta blocker with survival and pulmonary function in patients with chronic obstructive disease and cardiovascular disease, it showed that in this study, about 49 studies were included, about 6 lakh patient samples has been taken, and they found that beta blocker reduce all-cause mortality, in-hospital mortality in patients with COPD with cardiovascular diseases. And cardiovascular selective beta blockers reduces COPD exacerbation, and they do not affect the action of bronchodilator also. This is another study published in 2021, beta blocker therapy in patients with COPD, a systematic literature review and meta-analysis with multiple treatment comparison. In this study, they found that propranolol was the only associated with deterioration of the lung function in various RCTs. And other beta blockers have a same efficacy and they have very lesser effect on decline in FEV1. Another study regarding the beta blockers on the risk of COPD exacerbation. It is a Rotterdam study where 1,312 COPD patients were enrolled, and use of cardioselective beta blocker reduced the risk of exacerbation in COPD patients with cardiovascular disease. So another 2 trials regarding the COPD, but they don't have any cardiovascular diseases like block trial in which 532 patients included. COPD with moderate or severe intensity. And in this trial, they found that COPD exacerbation was similar in both the group, in the metoprolol group as well as the placebo group. So they found no benefit of using metoprolol or beta blocker in patient of COPD without any cardiovascular diseases. Another trial is a BIGS trial. It is a trial of bisoprolol in patient with COPD at high risk of exacerbation, but they don't have any underlying cardiovascular disease. And they also found a similar result at the block trial. So whenever you are using the beta blocker in COPD patients, so COPD patient with cardiovascular disease, so there is a cardioselective beta blocker reduces the risk of exacerbation. They have effect on mortality, reduce the mortality and exacerbation also. But COPD without CVD, like in block trial and BIGS trial, they showed that there is a no benefit of using beta blocker without CVD, and they have shown that increase in COPD exacerbations. Gold also suggests in 2025 that selective beta 1 blocker should used only in patients with COPD with cardiovascular disease patients. So this is a evidence-based regimens how the beta blocker should be started in patient with the COPD with heart failure. So in bisoprolol dose is 1.25 mg OD starting dose, and target dose is about 10 mg OD. Carvedilol dose is 3.125 mg BD and target dose is 25 mg BD. Metoprolol dose is 12.5 to 25 OD and target dose is 200 mg OD. Nebivolol dose is 1.25 OD and target dose is 10 mg OD. So double dose every 2 weeks is tolerated. Watch heart rate and individualize the treatment. This is another study regarding the bisoprolol comparative analysis with carvedilol. It showed that bisoprolol induced demonstrable improvement in pulmonary function test and caused less adverse event. This is also similar studies has showed that pulmonary adverse events occurred more often in carvedilol group and the effects were lesser in bisoprolol group. So bisoprolol is much safer than carvedilol. And bisoprolol is a highly lipid insoluble drug and less sleep disturbances and nightmares seen in bisoprolol, and it's longer acting and tend to be effective in narrow dose range. This is another study. It showed that beta blocker risk increases the bronchoconstriction, most commonly seen with the carvedilol and lesser with bisoprolol. And this is another study showed that COPD exacerbation rate is 30% decrease of relative risk with beta blocker. It is a study data from the COPD gene cohort study. And beta blocker also showed the all-cause mortality benefit in COPD with cardiovascular risk. There is a 30% reduction of relative risk with beta blockers. So which type of beta blocker recommended in patient with heart failure and comorbidities? In COPD patient, bisoprolol followed by metoprolol, nebivolol can be used as safely in patient with COPD or bronchial asthma. So this is my summary slide. Non-selective beta blocker like propranolol are contraindicated. Cardioselective beta blocker, bisoprolol, nebivolol preferred over to metoprolol and used where there is a no suitable alternative. Indication only when in patient with COPD or bronchial asthma having underlying heart failure with reduced ejection fraction as well as post-MI patient. Initiate at low dose, start low and go slow. Overseen by specialists and closely monitoring should be done in those kind of patients. Thank you so much. So always when you are going to choose your beta blocker, always choose the right choice. Highly selective beta blocker can be used and non-selective beta blockers should be avoided in patients with obstructive airway diseases. Thank you so much.
Hi, good evening, everyone. This is Dr. Prajay Lunia. I'm a consultant chest physician, a sleep specialist and intervention pulmonologist practicing at Holy Spirit Hospital, Bharati Arogunidhi Hospital, and most of the Western hospitals in Western suburbs. It was a great talk by Dr. Jyoti Bajpai Madam. Thank you, Dr. Nitin Abhyankar sir, for the excellent moderation. Thank you, CCI, and special thanks to Dr. N.H. Krishna sir, Narayana sir, Dr. Ravi Doshi sir, Dr. Atri sir, Dr. Vijay Chetty sir, and other council members of the CCI. Today we are here to discuss the topic contraindicated drugs in obstructive airway disease. Till now, we have been listening drugs used in obstructive airway disease. Let us understand which drugs are contraindicated in obstructive airway disease and why. NSAIDs. We have been listening about aspirin and NSAIDs. They are the most common prescribed drugs in the world because of the joint pains and multiple issues. They are the most common cause of hypersensitivity reactions. The prevalence ranges from 5 to 12%, 7% among adult asthmatics, and 14% among severe asthmatics. It is rarely seen in children. Hypersensitive reactions to NSAIDs have been classified by the European Academy of Allergy and Clinical Immunology and European Network of Drug Allergy. There are by two methods. One is the mediated by this COX enzyme inhibition. There's a pharmacological reaction which can lead to NERD, that is NSAID exacerbated respiratory disease, or it can lead to cutaneous disease, can lead to urticaria or angioedema, and there is a cross intolerance to various COX-1 inhibitors. The second mechanism is by immunologic mechanisms. It can lead to a single NSAID-induced urticaria, angioedema, or anaphylaxis, or single NSAID-induced delayed hypersensitive reaction. This is mediated by immunologic mechanisms. NERD, when we say NSAID exacerbated respiratory disease or aspirin exacerbated respiratory disease, particularly if you subtype, if you say, which was initially called Samter's triad, characterized by moderate to severe asthma, high prevalence of chronic rhinosinusitis, and the symptoms get exacerbated by the intake of the aspirin or NSAIDs. Characterized by persistent eosinophilic inflammation in the upper and lower airways, there are three phenotypes. There is rhinosinusitis, urticaria, and atopy, which helps in classifying into four subendotypes. You can have with NERD with CRS and atopy. There is no urticaria. Second one is with CRS, but there is no urticaria, no atopy. Third is without urticaria and CRS. And fourth is a severe one with acute or chronic urticaria exacerbated by NSAID exposure. NERD is characterized by chronic, there is a type 2 inflammation, which are responsible for the upper and the lower airway symptoms, chronic persistent asthmatic symptoms, CRS with or without polyps, and which are exacerbated by aspirin or NSAIDs. And that is why they are refractory to your conventional medical or surgical treatment. That is why patients keep on getting these symptoms even after the surgical treatment. Some patients can have cutaneous symptoms in the form of urticaria, angioedema, flushing, or gastrointestinal symptoms. It is more commonly seen in females, middle age, and they are non-atopics. The presentations are varied and the courses are also varied. That is why the treatment changes. That is why it is a heterogeneous condition. This is the diagrammatic representation of the various aspirin exacerbated or NSAID-induced hypersensitive reactions. The pathophysiology, why does it occur? As we have told that NSAID causes inhibition of the COX enzyme, and because of which what happens, the arachidonic acid normally is metabolized by two pathways. One is the COX way and the second is the LOX pathway. So NSAID causes inhibition of the COX enzymes. So that is why the arachidonic acid, they are metabolized by the LOX pathway. It leads to increased production of the leukotrienes by lipoxygenase, prostaglandin, especially prostaglandin D2, and there is a decreased production of the prostaglandin E2. That is why it leads to increased overproduction of the cysteine leukotriene, which causes bronchoconstriction. It leads to inflammation with the eosinophils, accelerated type 2 hyperinflation. Increased PGD2 levels, they leads to increased binding of the receptor, leads to bronchoconstriction, and leads to chemoattraction by binding to the chemoattractant receptor cells on the type 2. That is why it leads to accelerated Th2 airway inflammation. There is a downregulation of the PGE2, which is responsible for anti-inflammatory effect. And that is why ultimately it leads to bronchoconstriction and the chronic persistent hyperinflation in the airways. That is why in investigation you get blood eosinophilia. It is ARD is usually a clinical diagnosis. There is no hetero test which can confirmatory give a diagnosis of NERD, that is NSAID exacerbated respiratory disease. Leukotriene E4 levels in urine has been found to be most reliable marker. The other investigations are serum periostin and folliculin, but no further validation has been done for this test. If you want to diagnose it, you have to do aspirin challenge test. There are three methods by which you can do is oral, nasal, or bronchial. The most easy is the oral route. You start with 20-40 milligrams, slowly increase the dose every 2-hourly interval. If there is no reaction occurs within 3 hours after 25 milligram of aspirin, the challenge is said to be negative. Patients who have low FEV1 or unstable asthma, you should avoid doing this test. This should be performed in a hospital because you never know which patient may develop anaphylaxis. If you get a false negative and if you're still suspecting challenge to be positive aspirin sensitivity, you should hold leukotriene modified drugs, antihistamines, and corticosteroids for at least 1 week, and then you perform high dose aspirin challenge test. How you treat it? Say there is a condition where you have to give aspirin or NSAIDs, then how you treat it? You avoid the culprit drug. You can use selective COX-2 inhibitors, that is celecoxib, or partial inhibitors like acetaminophen. Treat asthma and rhinosinusitis as per the guidelines. because there is an overproduction of the leukotrienes. So you use the leukotriene receptor blocker, that is montelukast, zafilokast, or the inhibitory pathways, that is the xylitol, because that will help in improving the upper and lower airway symptoms. You can do an aspirin desensitization as a provocative measure. You start increasing the dose slowly within a period of 1 to 3 days, which can induce hypersensitivity. So this was about NSAIDs. Now there are other agents like mucoactive agents like mucolytics. You have classic mucolytics like carbocysteine, edosteine, and acetylcysteine. You have peptide mucolytics, which are used in severe conditions like cystic fibrosis, in which mucus is thicker. The agents are dornase alpha, thymosin beta. The other mucoactive are expectorants, mucokinetics, and regulators. They are all found to be very useful because they help in thinning the mucus and expectorating out and help in decreasing the symptoms, but sometimes they lead to bronchospasm. So how to avoid that? You should give a bronchodilation, especially before giving a nebulized N-acetylcysteine. Opioids, they are good drugs, especially in reducing anxiety, the pain, especially post-operative. But we have to be very careful in patients with COPD because they can lead to insomnia, depression, and respiratory depression, especially by depressing the central nervous system, which can lead to hypoventilation and can lead to CO2 retention, especially seen with morphine and codeine. It can cause constipation and urinary retention, especially when you are using with muscarinic antagonist. That is why it has to be very carefully used because it can increase the breathlessness. Antihistaminics, they are used for other allergic conditions. You should avoid using first generation antihistaminics like diphenhydramine, chlorpheniramine. You should prefer using fexofenadine or belastine. Sleeping pills you used because the patients do not normally get sleep. Alprazolam, clonazepam, they can cause respiratory depression and can hyperventilation and ultimately CO2 retention, especially in patients with COPD and OSA. So we have to be carefully monitoring these patients. Diuretics, they are used for patients with COPD with right heart failure or left ventricular failure, help in reducing the congestion by causing more diuresis. Have to be monitoring this patient because they can develop electrolyte imbalance, especially hypokalemia, which can lead to muscle weakness and can lead to respiratory fatigue. Sometimes hyponatremia can lead to altered consciousness and can also affect the and can lead to hypoventilation. Diuretics commonly used are furosemide and spironolactone. You have to be very carefully monitor the side effects and the electrolytes and take a combined decision with the cardiologist. Oral corticosteroids, they are wonderful drugs, especially in pregnant patients to control your severe asthma. But we have to be very careful in the first 3 weeks, the first 3 months of pregnancy, because there have been reports of increased cases of cleft lip and cleft palate and of premature delivery and increased risk of low birth weight. So we have to balance the risk and benefits. So because if you do not control asthma properly, hypoxia can have more detrimental effects to the fetus and the mother. Oxygen. This is a last resort for COPD. They are very much useful when your patient saturation is below 88%. But we have to carefully monitor it because if you give more oxygen to treat hypoxia, because that is a respiratory drive, it can lead to loss of that drive and can lead to hypoventilation and can lead to CO2 retention. And especially when you're prescribing home oxygen concentrator, you have to see facilities there or not there at home, because if it's not, then if it's near your gas stoves, it can lead to fire explosions. So we have to be very careful while prescribing oxygen. I hope I was little being able to give certain take-home message to our patients and the society about the drugs which has to be very carefully used or contraindicated in patients with obstructive airway disease. Thank you very much. Thank you, CCI. Over to you, Dr. Nitin Abhyankar.
Thank you. Thank you, both of the wonderful speakers. Dr. Jyoti, I must congratulate you because you involved so many meta-analysis, and that was great. So that part of your talk was really the highlight. And, that has put most of the questions related to beta blockers into a certain zone of comfort, no doubt about it. And Prajay, I once again must congratulate you on being really, going wide into the spectrum of the NSAIDs and the other drugs, and great job done. I think you have raised a lot of questions, and I'm sure the panelists which I'm going to invite are going to be the experts who will at least partly answer these questions. I have always found that whenever I am on a CCI webinar, I learn a lot. So I never realized there was a beta 3 thing going on there, somewhere. And I think Jyoti's talk, I used to think it's always beta 1 and beta 2, and that's the end of the story. That beta 3 is, well, thank you very much for reminding me of that. I probably learned it, but I forgot. So let me invite our two other panelists. Dr. Gopal Krishnan from Vijayawada, welcome to this panel discussion forum. And thank you. And of course, last but not the least is Dr. Pramod Jhawar from Indore, my dear friend from a very, very long time from Indore. And we were discussing while we were just going through it. So welcome all of you, my entire CCI family. We did CCI Con 4 in 2000, just before the pandemic lockdown in January in Pune. And we have the opportunity and fortune to be having the NAPCON in 2020-25 beginning in 24. I hope there is no lockdown after that. But at the same time, everybody who is coming here, I'm sure the entire CCI family is going to support us big way. So I think let us start the discussion. I'm just playing devil's advocate. Very frankly, the concepts have been clarified reasonably by everybody, but at the same time, I have a few questions in my mind, and I'll start with Dr. Pramod, sir. We talk of aspirin-sensitive asthma, and aspirin is so badly needed a drug. I mean, there is no two questions about it. So, can aspirin be used in aspirin-sensitive asthma? If yes, how? And if no, then what are your other options? What are we left with? I mean, are we going to go to things like, clopidogrel, or that seems a little bit too much for it. So you're on a mute, sir.
So good evening to all, and it is my immense pleasure to be the part of this panel about the important discussion. As the aspirin-induced aspirin-sensitive asthmas are very much common around, it is to the extent of 20% in the case of adult population. But they may be the aspirin-induced asthma, and some is aspirin-exacerbated respiratory disease. They are the two parts differently resistance, and there's basically a triad of the symptoms like allergic rhinosinusitis, nasal polyposis, and lower airway diseases, and which are being triggered by the aspirin and NSAIDs drugs usually. And most of them occurs with a hormonal alteration, because aspirin-induced asthmas are usually occurs when the hormonal alteration in the pubertal children and women in the age like late 30s, 40s, like they're going to occur. And allergic aspirin-induced asthmas are yet to wide variants of the non-specific allergens also. So there is a aspirin, if it is sensitive, you must avoid, because it is the cytogenous pathway from where it is acting. There's a metabolism of the aspirin is altered, and this is causing the bronchoconstriction in the airways, which is causing more symptoms.
One wonderful answer. I think, Jyoti, you want to add anything to this aspirin controversy? You are on a mute, Jyoti.
Sorry, sir. So, yeah. So well said by Dr. Pramod regarding the aspirin-induced or aspirin-intolerant or aspirin-sensitive asthma. So in this acute situation, we have to avoid aspirin, but we have another drugs like Dr. Prajay also covered in his lecture, like celecoxib, and because aspirin is a non-selective COX inhibitor, so we can use a selective COX inhibitors like celecoxib and paracetamol. can be used in that kind of cases. And regarding the other blood thinners, so might be if there is a aspirin is a very important drug for the cardiologist, and it's a very commonly used by the cardiologist, and other diseases also. So if there is absolute contraindication not to use aspirin, so we can use a clopidogrel, ticagrelor, and prasugrel as per the cardiologist's prescription. And another thing is as aspirin induced aspirin exacerbated AERD is another term, aspirin exacerbated, yeah, NSAIDs exacerbated respiratory disease, NERD. So in that situation, might be we give a challenge of aspirin challenge test or desensitization. Aspirin desensitization can be also done by the gradual dosing, and already covered by the Dr. Prajay in his lecture. So this might be we can give in any RD kind of diseases, aspirin we can use, but in acute extranasal bronchial asthma, it should be avoided and as use another drugs.
Excellent. I think I'm going to go back to Prajay the other way around and ask him about beta blockers, because I think he spoke about, I mean, you spoke about the beta blockers. So let Prajay come back on this and say, which beta blockers are best avoided in asthma? And I think it's going to be a little bit of repetition, but I think it's worth repeating because some things are worth repeating 1,000 times because they go better and more sensibly. So can beta blockers be used in COPD, and then which molecules?
So the first question was which beta blockers to be avoided. Like non-selective beta blockers like propranolol should be avoided.
Yeah.
And in terms of like cardiac safety wise, as we discussed, because there's always like a combined decision. It's not the pulmonologist have to take a call. It's always a decision with the cardiologist. So what we have seen that they always prefer a cardioselective beta blocker, like as Dr. Jyoti has already said, either carvedilol or nebivolol. They still don't prefer metoprolol over carvedilol. They always prefer carvedilol or bisoprolol or nebivolol first. And if we are not able to use it or it's not getting the good results with that, then they prefer using a metoprolol.
Correct. So I think the sequence goes in favor of bisoprolol as the best. I mean, is that your best choice, one way or the other? So suppose if you are given the right of prescription, would you write bisoprolol first?
Bisoprolol first, then I would come with metoprolol or
of course, mostly they don't give us the choice, but
yeah.
So Prajay, I think wonderful answer. I'll come to Dr. Gopal Krishnan and ask him something about, do you give a suggestion of a relatively safe NSAID to your patients as a standard of care? I mean, I think most of us are doing that. So can you enlighten us on a little more on that, Dr. Gopal Krishnan?
Yeah. If NSAIDs are mandatory or is it necessary, I prefer to give COX-2 inhibitors because it's relatively safe. It's like regular non-COX-2 inhibitors like diclofenac and aceclofenac can cause severe bronchospasm and exacerbation of asthma. So patients who are sensitive or who are having aspirin-related acute exacerbations asthma, it's better to avoid NSAIDs. And patients with poorly controlled asthma and history of chronic rhinosinusitis, nasal polyps, and patients with, especially with female gender, they are having more risk of NSAID related exacerbations. So better to avoid NSAIDs in these patients.
Yeah, I think wonderful answer, Dr. Pramod. Can I ask you a little tricky question? Is paracetamol today the safest option in asthma, or you have some other choices if you want to?
Although paracetamol is a better option, acetaminophen, in case of allergic disease, but even they say the smaller dose, when you up titrate it on high dosages, they can be causing the bronchoconstriction. So it is not clear cut that paracetamol is 100% safe and is without bronchoconstriction. But many patients in a low dose, they may not going for the bronchoconstriction, but very safely used. Yeah. In case of it. And other way around, if it is nothing, any drugs remain, is then nimesulide is one of the better options because it is safer in asthmatic patients.
I mean, this is an open question to everybody. Nimesulide was a wonderful drug in my practice for asthma for a long number of years before it got blamed for that Ray's syndrome in pediatrics, and then gradually got almost obliterated from the entire spectrum of practice, I still find it's not a bad drug at all. I mean, etoricoxib is another good choice, but nimesulide was not a bad choice at all. What's the take of the rest of the panel, please? I mean, anybody who has to say anything.
Actually, it is more of the awareness which has been developed. Probably we don't get that much amount of cases because of the nimesulide induced that reactions. And if you take the proper history, and if a patient is giving a history of an asthma along with rhinosinusitis or nasal polyp surgeries, then you better avoid in that patients. But otherwise, you can definitely use nimesulide also.
Yeah. And what's your take on, I mean, anybody else on etoricoxib is one of the better ones? I mean, any of those coxibs, are they really good enough, safe enough? Naproxen is another thing which I have in my mind. I mean, in the terms of, because these are the questions in the audience's mind. So I'm just trying to express them to you all. You have any preference, or are you are dead against any of these other choices?
No, the coxibs are always preferred. From my personal point of view, naproxen or this, I would give it at the lower this thing.
At
But
lower.
coxibs, yeah, at lower. Coxibs,
Yeah.
then nimesulide, and then I would prefer giving an
Then you will use very nice answer. I'm going to ask to Dr. Jyoti, do you routinely or individually use RAST-like blood tests for looking for drug allergies? Is it recommended in your practice? Are you doing it routinely? What is your take on this?
So
And
I would like to
I'll go
say,
for
yeah, so I would like to say that for drug allergy, identification of the drug allergy, I am not going with the routinely with the blood, any kind of test, but clinical symptoms and how long the symptoms has been established after taking the drug, it is important. Duration is important. And another thing is sometimes we get some increased eosinophil count might be seen in the some of the drug allergy, stress syndrome kind of situation we can identify. So I am not doing any kind of drug allergy blood testing, as I'm not aware of any kind availability of drug allergy testing. But some of the blood markers and urine test can be done, but they are not recommended in any guideline. So history is a very important role, play a very important role in diagnosing drug allergy cases.
Dr. Jyoti, I think the part of guidelines not recommending is very clear.
Yeah.
Availability of drug allergies is tremendous in this country, and so-called drug allergies. So I think I meet people every day saying this huge big list of drugs, and God knows whether they have ever taken any of those drugs, including foods. People are allergic to wheat, bajra,
Yes.
rice, and they are left with almost nothing to eat. So kind of, that kind of allergies, which is sensitization and not true allergies. So, I mean, I take it with a pinch of salt, but I think, if any one of the panels, I have to add, Pramod, please come in.
The drug allergy is a very vast subject, and clinically to me, it is only the history is very important. What drug patient has been exposed and cause the immediate reaction or the delayed reactions. Because of the many times the drug may not cause the allergy, but excipients can cause us in a second bypass to the liver, and they can cause allergies. Like so, it is because it is just like a Cifran OD is only one sodium component, and Ciprox is BD. But the expert is going to change for their drug delivery system. So I think the first and most important is the history, and then the drug rechallenge test is only one important, whether the drug is been culprit for it or not. That's all.
Beautifully said. I think even an inhalation challenge is imaginary. A direct oral challenge is possibly one of the best ways of, and then what, as Prajay said or as Jyoti said, gradual desensitization is always possible. So I think one way or the other, if I really suspect something really necessary to be prescribed, and at the same time I'm a little worried whether it is going to cause an allergic reaction, I would do that gradual desensitization business rather than going into so-called allergy testing and say, okay, you are forever not to take aspirin, forever not to take whichever drug, which is otherwise extremely life-saving or valuable to that particular individual. So I think very beautifully said. I'm changing tracks, and Dr. Gopal Krishnan, this is for you.
Yes, sir. Yeah,
Uh,
yes, sir.
we are looking at a scenario where a lot of people undergo general anesthesia, and some of them are exposed to inhalation anesthesia. I think that is a decreasing trend over a period of time, but some of them land up with the bad asthma exacerbations, particularly those who are prone to it. So, do you have any insights on this? I have attended a number of patients who actually had to be sort of from the operation table directly taken to the ICUs, managed over days altogether, and sometimes even a near cardiac arrest situations. And one of my patients is alive after 25 years after his near cardiac arrest kind of situation. So I think, is there any insight on the inhalation and anesthetics in your mind? I'm not saying they
Yeah.
are contraindicated. They are indicated because of the need for the anesthesia. But at the same time, they can be precariously dangerous to some people.
Yeah, definitely, sir. Inhalation, because inhalation anesthetics will cause some amount of airway inflammation and irritation that can lead to bronchospasm and exacerbation during the procedure or maybe immediately after the surgery. So, patients who are having like poorly controlled asthma or having any allergic reaction to drugs, better to avoid the inhalation anesthesia and prefer trans in Taiwan instead of inhalation anesthesia. But the present available inhalation anesthetics like isoflurane and sevoflurane are well established and their safety profile is very good. Most
Very
of the patients will tolerate this inhalation anesthesia well, especially with patients with controlled asthma.
Yeah,
And if those are asthmatics, it's better usually it's give hydrocortisone at least 2 to 3 hours before the procedure can subside the inflammation, and it will give a good result.
absolutely. Prajay, I'm coming to you on this extended question on the same topic. Do you have any tips and tricks related to the TIVA? Because he already mentioned TIVA. So I think, which TIVA drugs, do you have any insights on this?
So, like as doing the bronchoscopies also nowadays, the anesthetists, when they're giving intravenous
Absolutely.
anesthesia,
Yeah.
so when they come to know that when the patient has asthma or COPD, they prefer giving a ketamine.
Exactly. Absolutely. You are
So
spot on. I think
one day
totally
I
right.
also got surprised. So because post procedure, I was not expecting my patient to be very altered, behaving something like that. So I asked him like, you have
They get
changed.
that clenched teeth kind
Yeah,
of
so I
scenario.
was like,
So,
"Hey,
क्या दिया
actually,
तुमने?
in so many years, like never I've seen patient after scopy behaving something weird and some different. So I was also surprised. So he told me I have given ketamine. So I asked him why. No, because it has a bronchodilator reaction.
Reaction. Absolutely.
So that is the thing. So I think so. We should have a discussion with them also that we definitely don't need that much bronchodilation during our procedure of bronchoscopy, only because of the fear that the patient might cough because of the like biopsy. There is a bleeding. To avoid that, they preferably give ketamine.
Absolutely. And of course, I mean, then there are issues related to the first dose hypertension and things like that with
So instead of just
propofol
waiting for half an hour post procedure, then I had to wait for 2 to 3 hours for that patient to be in the
after
recovery room.
become normal. So, I mean, you have a longer problem related to a drug which you really didn't order for.
Yeah.
Pramod, you had something to say?
So in this literature where I'm taking into my education, and there is some sorts of when this anesthesia is prolonged, and there's a release of the some calcium ions into the blood from the skeletal muscles, and
Yeah,
which is sometimes causing hyperthermia and sometimes muscle rigidity in the patients. And these are some of the points which we are not getting mostly.
yeah,
But all this premature people and critically ill patient get absorbed systemically more and more these sorts of inhalation anesthesia, and can cause respiratory depression and sometimes vomiting and sometimes hepatotoxicity. Some of the issues are there.
absolutely. I think one of the most underestimated side effects of beta agonists is hypokalemia, in my opinion, particularly when you are using a large dose in a nebulized form. And hypokalemia is something which you have to really look for and correct aggressively, because I think that can cause serious consequences. So if I think, I may make that as one of the important take homes, that I'm not saying it's a contraindicated drug, not at all. I mean, whenever you are using bronchodilator, you are using it for a bronchospasm, so it's not a contraindicated drug, but it's a drug which is used with caution and monitored carefully for an important side effect like hypokalemia. I think this is one of the most important ones. Anything else in your minds? I mean, everybody in the panel can
Sir, I
opine.
want to add one thing, sir.
Yeah, Dr. Gopal, question. Yes.
Yeah. So nowadays, actually, we stopped doing procedures under general anesthesia. So most of 90% of our procedures we are doing under TAIVA, and our preferred drug is propofol.
Yes.
So because it can reduce the laryngeal reflexes and bronchoconstriction. Patients are absolutely fine with propofol. Even with low dose, we can comfortably complete the procedure, and immediately that maybe THAF is very, very less, so patients will be absolutely fine immediately after the procedure.
Correct. I think Midas fentanyl is the first line. Propofol is the immediate next choice, and isoflurane and other things, and Keta once in a while. Keta is extremely rarely needed, very, very rarely needed. But I think if you are really, really looking at a person who's getting into spasm, more often I see apneic patients rather than bronchospasm patients on table while I'm doing a procedure. So most of the times our nebulizations or whatever we are doing before are good enough to take care of their bronchospasm. It's often the too much of sedation causing apnea which is causing more problems rather than the other way around. So I hope I'm agreeable to rest of the panel, and we'll move on with this question to Dr. Jyoti. Are you more worried about drug allergies in asthma, obstructive airway disease, in certain endotypes? Do you? I mean, I think somebody had a passing mention onto chronic rhinosinusitis and things like that. So, is there more preponderance to drug allergies in certain pheno or endotypes?
Aspirin-induced asthma or drug in most commonly drug causing asthma or allergy is aspirin. So most commonly it is seen in allergic type of bronchial asthma. It is one kind of phenotype, because we know that there are a lot of phenotypes like allergic asthma, non-allergic asthma, obesity-induced asthma, and late onset bronchial asthma, cough variant asthma. These are the various phenotypes, and their pathogenesis comes under the endotypes of bronchial asthma patients. So aspirin-induced most commonly seen in a patient who having a type 2 kind of inflammation or allergic type of bronchial asthma, but they are non-atopic type of aspirin-induced asthma is non-atopic kind of asthma. So, but most commonly seen in type 2, high type 2 inflammation kind of asthma, we see the drug allergies.
Absolutely.
So this is a paradox kind of thing. We see
seems the other way around, isn't it?
Other way around, yeah. Yeah, so in that kind of cases, we are more worried and we are more vigilant whenever we are giving a aspirin. But I have not seen much of the aspirin-induced asthma in my clinical practice, because we are we are not getting much of referrals from the cardiologist regarding this. So I just want to ask all the panelists regarding this, that I have not seen in the last 11 or 12 years in my practice ever ACE inhibitor induced cough we see frequently, very frequently.
Almost
Aspirin induced bronchial asthma, as the literature says, but in our practice, I've not seen much of referral from the cardiologist. So, what is the take of others?
So I'll contribute. There was a drug called Chamatkar in my city, and that Chamatkar induced probably had a lot of ibuprofen in it. And one way or the other, we have seen a lot of chamatkars because of this chamatkar drug. So, I mean, if you do something in excess and ridiculously madly, then you are going to get into problems. But I think most of the time people are today cautious that you have to prescribe drugs in asthma with caution. Dr. Gopal Krishna, you had something to say on this. Please come in.
The drugs with caution.
Yeah. No. We were saying about she was asking about you have aspirin-related problems. So
Exactly. I agree with Dr. Jyoti. I have not seen a single case of aspirin-induced asthma. We are seeing we are reviewing in literature literature, but practically it's not seen, sir. But what Dr. Jyoti said is absolutely right. ACE inhibitor related asthma is cough is very, very common and very frequently we'll see in our day-to-day practice. So I think we should be very cautious when patient came with like undiagnosed cough. We have to look for a patient is on any ACE inhibitors and non-selective beta blockers.
Yeah, Pramod, you wanted to come in on this?
Any patient of asthma, obstructive disease when comes, and many times the physicians are sometimes there's a 3-4 drugs are very much common, like ACE inhibitors.
Yes.
And the beta blockers. First, I would like to know whether they are culprit for or not. Number one.
Absolutely.
And many patients are being ACE inhibitors. Cough is very high, and even as this Dr. Jyoti has said, I haven't seen any patient with the aspirin induced like exaggerated, because those patients being initially get diagnosed earlier whenever there is a problem into this childhood age, younger ages, but not into the adult.
Anybody else in this? Prajay, Jyoti, you want
similarly, less
This
cases.
is a high time we have to generate our data and we have to tune our cardiologist regarding this. Might be because we get referral from the cardiologist because we are not prescribing so much of aspirin to our patients. So cardiologist prescribing and might be something is missing, or we have to generate our data regarding this.
So crosstalk will be a better idea.
Yeah. I think this is a better one.
I want to add one more point.
Dr. Krishna is very carefully listening to this. I'm sure there is going to be a crosstalk very soon. Let's look forward to that.
Now, what is the cardiologist perspective on this?
Absolutely. Prajay, you had something to say?
Similarly, because it is more commonly actually, I have never seen like this kind of a cases. So when I was also preparing for this talk, so I was also like, so much is there for the NSAID-induced exacerbation of the respiratory disease. And the reason behind is probably it is more commonly seen in middle-aged females, and normally middle-aged females having cardiac issues and all that are lesser. That is why, because they are being protected by the estrogen and the progesterone hormones. So that is why we don't get the cross references from the cardiologists, especially with the middle-aged females.
Absolutely. Yeah. I think I'm going to change track a little bit and ask about drug interactions related to ICS, because our core prescription is ICS, possibly ICS LABA today. And I mean, do you think, because some of my IID specialists, particularly when it comes to HIV medicines, because HIV medicines is like more or less a lifestyle medicine, and when they have asthma, coexistent asthma, they often talk about budesonide having problems, budesonide not to be given because it will interact with the HIV drugs. So have you come across this kind of a situation? I mean, and if at all you have come across this, what is your alternative best? I'll start with the most tricky question. So Gopal Krishnan, sir, let's start with him.
Yes, sir. Thank you. Actually, by practically, I have not seen any drug interactions with, especially with inhalation corticosteroids. But what literature is saying that inhaled corticosteroids can interact with some drugs, like especially what you said, like protease inhibitors and some calcium channel blockers, clarithromycin. So the main mechanism behind this is because all these ICS has having potent CYP450 inhibitors, so that can increase the prednisolone dose and it will cause unselected steroid-induced side effects. So as per literature, it's better to monitor the inhalation steroid-related side effects whenever patients are having like other medications like protease inhibitors and calcium channel blockers, clarithromycin, and antifungus like voriconazole.
Yeah, but I think voriconazole is a tricky drug, isn't it? I mean, one way or the other, particularly itraconazole, much worse in the terms of absorption, but voriconazole has otherwise excellent absorption and bioavailability, but then gets interfered by various inhaled corticosteroids or one way or the other. So I think that's something which you have to be. I'm not saying we have to be absolutely worried about, but at the same time, be a little aware about, keep it there in the background. And if something is not working out, we probably have to go back to the drawing board and start all over again, or maybe increase the dose. Any thoughts on this voriconazole, itraconazole story? ABPA, we use both drugs very commonly. and oral steroids also.
What they say ki the voriconazole drug when used in with the steroids, it is voriconazole dosages this clinically get decreased, so it is not optimally working. They have to increase
you have to
the
upregulate.
upregulate, and sometimes with the use of this clarithromycin and macrolides, again the dosages get the higher over.
Excellent.
I think that has to be kept in mind while using the varicazole with steroids and macrolides.
If there are no other thought processes, if there's somebody, no, there's no raised hand. So let's move on. And I think this is $1 million question, because I think this is the way the asthma treatment is moving towards in future, that we are talking about better safety profiles, more beta to selectivity, and fluticasone furet and vilanterol is possibly the new kid in the block in the terms of, the safety, which is unparalleled. 2000 times more beta to selectivity when it comes to vilanterol. And are we moving one way or the other 100% in that direction? Or there is still time yet and we still have to learn this a little better? So I want everybody's opinion on this. Yeah. We'll start with Pramod, sir. You are on the screen.
Sir, what happened? The asthmas and the COPDs are sometimes with the late onset, like 40 years, and again there is a concomitant hypertension. Some of the CAD component is there, some diabetic and all. So that point of time when there is a comorbid conditions are very high, when the person on multiple drugs, like when you are certain cardiac arrhythmias and some sorts of LV dysfunctions are there, then you have to select the this beta 2 agonist on the safer side rather than. So I think vilanterol and the fluticasone is going to be future in the later age diseases management, where there's a so many comorbid condition. You want the safer option for to treat the asthma.
I also tend to agree with that, because I am not doing that for my younger asthmatics. But when it comes to 60 plus, 55, 60, 70, I'm more inclined towards using fluticasone vilanterol. Dr. Jyoti, can we come back to you on this?
Yeah, sir. So, yeah, when we are choosing ICS and LABA combination for the management of obstructive disease with other comorbidities, like in view of cardiac safety, pneumonia, and other parameters, so we have to choose mostly beta 2 selective, as you told that vilanterol is 2000 times higher beta 2 selective, so that is a better bronchodilation, and potency wise it is a good drug. So that's why currently in our armamentarium, the vilanterol fluticasone is the, regarding the potency, regarding the side effect wise, I think this is the good drug, and in all the trials it has shown good effects as well as.
I think we are seeing it in clinical practice as well.
As in COPD, like triple combination, also umeclidinium and vilanterol and fluticasone, these drugs is impact trial. They have shown a mortality benefit also, and they have shown a very lesser cardiac side effects. And so that's why these newer drugs and newer molecules are very good one. And when we are going to choose these drugs.
Prajay, your thoughts on this?
So same, like everybody's the thoughts are very true that these molecules are definitely, they are going to be the future. But there is little, I would personally say there is little time we'll have to wait for it to see what are the exact benefits and the side effects, because they have been, all studies have proved it. But when it comes into the market and when the people use it, we will actually get the exact picture.
Absolutely. I think you said it so beautifully, because, we say budesonide, the best studied drug in pregnancy, one of the best studied drugs in children. And we don't have that kind of data with, say, fluticasone furet, even though it is a much lower dose. And what, I don't know, but I'm surely not prescribing that in children, 5 years and 6 years olds. I'm going to be safer with budesonide. Pregnant women, I feel safer with budesonide because the data is overwhelmingly in favor, because of longitudinality rather than anything else. I mean, and of course, I'm in no way running down the newer drugs. Absolutely, they are indicated. Whenever I have a cardioselectivity in mind, I will definitely consider them very strongly. But I'm not going to go 100% to them in all situations and all times. I think, Dr. Gopal, Krishna, your thoughts on this?
Yes, sir, absolutely. Because that safety profile of budesonide was well established, but like Dr. Jyoti said, we need to have more data on these newer molecules, and we have to wait for some more time to see the safety profile of these newer molecules. But one thing I can say that it definitely this triple drug combination in COPD can reduce the risk of exacerbations and hospitalizations. This is our observational study. It's keep going on, but we need a more data, sir.
Absolutely, absolutely. So I think I'll come to one of the most controversial questions of the day. Uh, are we really thinking that inhaled corticosteroids and LABA, whatever, this is our gold standard in asthma therapy, are they foolproof safe medications, or they do have some problems with them also, inbuilt within them? I remember Dr. Atul Mehta's lectures in number of meetings that I've attended, and said, and he's shown bronchoscopically there are troubles, even the local. We are not talking of the systemic, but even local. So inhaled corticosteroids may not be 100% foolproof safe. Your thoughts, everybody, one by one.
So yes, you rightly said, inhaled corticosteroid and LABA combination is, I think this is the best therapy and main therapy for the management of bronchial asthma, because we can't use isolated SABA in bronchial asthma patients. So currently, this is the best therapy for bronchial asthma patients. But still, we have a lot of side effects like pneumonia, incidence of pneumonia, 2 to 4% cases of pneumonia, and there is a incidence of glaucoma also with the use of high dose of corticosteroid for more than 3 months of therapy. Seen the narrow angle glaucoma can be seen with the use of inhaled corticosteroid also. So this is a very bad complication of corticosteroid, and because in this patient can lose his vision also because of the optic nerve involvement. So one thing is that, so nebulization can be used, but in a proper optimized dose with the proper timing of nebulization drug should be used in cases of bronchial asthma and OAD, and other skin manifestation also, skin side effects also, diabetes, and as I told, osteoporosis. So there are a lot of side effects, but yeah, they are lesser with the in comparison to oral drugs, oral corticosteroid, but still we have these kind of side effects in our patients.
Yeah, very well said. And anybody else has anything to say on this issue?
What I will, because when you are taking the Rotacaps are the highly prescribed drug in the rural areas, because all are smokers and they know how to take the Rotahilas and Revolazers basically. And if we see hardly in a 32% drug deposition to the lungs and rest of the drug into the oropharynx, they cause the fungal infection there sometime if it's not gargling properly. So I think such much fungal infection is there if the patient is engulfing so many hard OHs, sometimes entangled with the lower end bronchus where the small airway dysfunctions are there. So I think so many complications can be because there's a study with the salmeterol fluticasone, the pneumonias and where they were. And I think so it is.
I think one of the things which I was alluding to is pneumonia risk. And, if you really see, even with one of the best stable molecule like budesonide, the odds ratio is 1.68. So it is pretty high, I mean, in that sense. So pneumonias are likely to happen more when I'm using it for years or decades altogether. But the simple clinical message which I have for most of my patients or most of my junior doctor colleagues is, one way or the other, we can manage the pneumonias. They are not life-threatening in the true sense. If I'm not using inhaled corticosteroids and the patient is repeatedly coming into a hospital and particularly in the ICU, then he's loaded with bad bugs, much worse bugs than the community-acquired infection. So I would rather accept the risk of smaller increase in the community-acquired pneumonia rather than a huge increase in the hospital-acquired pneumonia, particularly for COPD patients, which takes them into that downward spiral much worse. Then they get what is called as chronic bronchial infection, and they die much more prematurely. So I think, or you resort to antibiotics like nebulized antibiotics and so on and so forth. So I think you are in a more and more desperate zone. So if I am able to keep my patients off the hospital, that is a much better game. And therefore, ICS LABA still, despite having some problems with them. I'm not saying there are no problems, but at the same time, for example, I think one of the things which Vijay had put in the question is tremors. So, how commonly do you encounter tremors? This is one thing I'm going to ask everybody. We'll start with
So,
Gopal, sir.
sorry.
Or Prajay, you can go ahead.
So, that as you said regarding first, I would just like to add for that anal corticosteroid. Like one message I would like to add on. Now, no doubt everybody is checking the inhaler technique. What I would suggest, like if we don't have time, at least we should train our receptionist or the nursing staff to check the inhaler technique, because most of the times all the side effects is because of the poor inhalation technique. That is why you get all these oral candidiasis. And regarding the tremors which you are saying, the beta blockers, what I've seen, like most of the time when patient comes to us, the tremors are not because of the inhalers, but sometimes along with that, they are taking the syrups, which has a bronchodilator, that is terbutaline. That is the most culprit which is responsible for tremors. And people blame that inhaler is the responsible, because according to the patients, cough syrups will never cause tremors, but they
Yeah,
don't know what is there in the cough syrups.
absolutely. Very well said. Very well said. Absolutely. Dr. Gopal Krishnan, you had an input on this?
Yes, sir. We have to cross-check the drugs what patient are using. They may say like that tremors maybe not because of the cough syrup, but it's our responsibility to check the drugs. What are other drugs they are using? Most of the patients will be on like salbutamol oral dose or doxophilins, other all oral bronchodilator that we have to cut down and optimize the dose to reduce the tremors. Instead of
And
blaming the inhalation drugs, it's
you have,
better to.
you have brought me to a very tricky zone, Dr. Gopal Krishnan, and you'll have to answer that, and everybody has to. What is the real role of doxophilin, tauphilin in true asthma? COPD in a low dose sustained release, I also use it. But do I use it in asthma anymore? I mean, am I needing it in the true sense? Is it a value addition drug or it is just an additional drug?
I think it's just additional drug, sir. It doesn't have much action, but theophylline have definitely a established role in asthma, but not like doxepin.
Absolutely. Yeah, doxophilin seems a bit understudied and overrated, one way or the other, in
Exactly.
the entire Indian scenario. Any thoughts on this, Dr. Pramod? I mean,
The theophylline is a well-established, thoroughly evaluated drugs because the five actions are there. The broncho, smooth muscle relaxation to bronchus, and there's a diaphragmatic muscles getting activated. There's a diuretics because can be used in safety asthmatics and cardiac asthma. So it also stimulates the brain. Like so, theophylline is a better drug. But as far as point of the asthma is concerned, it is only add-on drug sometime
it's an
because
addition. Correct.
because you did not did any long-term anti-inflammatory action or something like.
Yeah. One of the last questions, and then I'll go to concluding remarks. And once again, I'm raising a bit of a controversy, but it's not based on my opinion. It is based on Gina's opinion. The GINA track 1 today recommends as ICS formoterol, whichever ICS you are using, along with formoterol as the first line choice, and SABA should not be prescribed as the add-on reliever. Only the ICS formoterol becomes the reliever. In my opinion, that's the best idea because, very frankly, I started doing 20 years ago studies on reversibility, and even today, the reversibility is tested on formoterol rather than on salbutamol because we never show our patients salbutamol, never show. I don't accept samples of salbutamol or levosalbutamol or whatever that SABA is. We never prescribe it, we never give it to them. We tell them use ICS LABA, which is ICS and formoterol. Budesonide may be one of the choices, fluticasone may be one of the choices, whatever it is. And I mean, as you move towards more cardioselectivity, you might move towards VA and formoterol. Sorry, Vilanterol and fluticasone for furet. So you get into better salts and better safety profiles, nothing else. But at the same time, of course, I mean, you can't be doing reversibility studies on VI for VI and Vilanterol fluticasone. But at the same time, ICS formoterol, as GINA recommends it, GINA 2024 guidelines recommended, is the first track. The second track is SABA as a reliever and ICS as a sole prescription. So, where are we today in India at this point in time? my tendency is definitely not to prescribe ICS alone. I would rather say ICS LABA as my first choice and the only choice, if at all. And I very rarely, in fact, I almost don't need it, except in occasional breakthrough, 3 a.m. kind of breakthrough attacks, which some COPD gets it. And he's on nebulized bronchodilators, nebulized formoterol budesonide already twice daily, and is requiring a third on top of kind of a dose. So I'll use a SABA as a reliever. So is that a right idea that SABA is a drug which is, I wouldn't say contraindicated, but relatively not so recommended in asthma as well as all forms of obstructive airway disease? So what's your thoughts on this? I mean, do you really need it? In which situations do you need it? So yeah, we can start with you, Dr. Pramod.
So in asthma, the basic pathology is airway inflammation, allergic inflammation. That is very important. And inflammation is only getting taken care by the inhaled steroids. And whenever the triggers, maybe the specific, some allergens or some non-specific, there's a bronchoconstriction and mucus production and causing. So I think the basic idea behind these guidelines to prescribe inhaled corticosteroid with the LABA is very important. It also proven in a smart therapy, it is a very useful. So I think in asthmatic patient airway disease, you must have this ICS and LABA combination to be used. So the ICS and LABA is important in asthma, bronchial asthma, and the rest of the part like this in asthma you have to use inhaled corticosteroids to just taken care for the inflammation and the bronchoconstriction by the LABA.
I think everybody else on this, and we'll go on to the audience questions. SABA monotherapy in any case is contraindicated, so that's not a question that we have to really answer. And so Prajay, what's your thoughts on this?
As you rightly said, I have also hardly used only inhaled corticosteroid. I normally prefer giving ICS plus LABA. Because either make it SOS basis or you give it as low dose, it becomes easy for the patients to be compliant also and to prevent and going into further and further exacerbation. And SABA is now almost out of picture. Hardly I don't think so anybody would be prescribing also SABA.
Yeah. I think that seems to be the tone most of the newer generation is onto. The older generation is still sold onto this idea. And if you really ask me, my general medicine colleagues are completely sold onto this. And an extremely interesting question, which Dr. Ajay Ranjawar also asked from Nagpur. Narrow angle glaucoma is due to ipratropium or ICS? Because the duolin thing combination, I'm sorry to use the brand name, but ipratropium and salbutamol. So I mean, that seems to be the standard of care. Day one, before I see the patient, and I'm invariably called on day 2. So day 1, everybody gets what is called as 4 doses of ipratropium and salbutamol nebulization, and at least 2 doses of budesonide nebulization. That's the standard of care in my ICU, which is I'm living with for 30 years. And still I have not been able to completely change my general medicine colleagues. Because their knowledge seems to be, I'm not saying bad things about ipratropium and salbutamol. In the terms of managing an emergency situation, they are great. When it comes to managing an emergency, and they are great bronchodilators. But the same story continues throughout the admission if it is not seen by a pulmonologist, and then they never go on to the formoterol budesonide kind of a combination or whatever else is appropriate. So do you agree with this? I mean, everybody.
Yes.
Dr. Gopal Krishna?
Yes, sir. I definitely agree with you, sir.
Yeah.
But one point I want to add regarding SABA is SABA is still having its role, but even though I might not recommend as a monotherapy, but it's still having its role in exacerbation of asthma.
Absolutely.
Without SABA, I think we cannot able to manage.
Yeah, and in fact, there is a big problem in our ICUs, which are, say, I'm a 15 physician ICU, which has got two pulmonologists, me and Dr. Vishali. So I think we are only two. So we are in a small minority, and the rest of the people are in a huge majority. And one way or the other, that salbutamol, even my intensivist, very frankly, I keep on correcting them every day, and gradually they are shifting towards formoterol budesonide is choice number one, at least on day two. I'm not saying on day one you do that. When somebody comes, reports to the hospital, he gets ipratropium, salbutamol. I have no problem with it as a first bronchodilator. But moment I realize that this person is more like a COPD, I would move on to formoterol budesonide or anything which is a little LABA based, rather than just continue giving 6, 7, 8 nebulizations of SABA. It makes no sense, very frankly. I mean, one way or the other, I need more bronchodilation, I need more stability, I need more lesser drug usage, and I don't want drug abuse. One way, in the long term, particularly what I'm worried about is drug abuse. Whenever there is a SABA involved, there is a chance of drug abuse. So I hope most of us agree on this.
Yeah.
Yes.
Yeah. So I think another question from Dr. Ajay Lanjevar, again, patient receiving salbutamol DPI MD for the first time do encounter tremors apart from ethylene syrups and tablets. I do
They
observe
will.
that. Though not in the majority of the patient, but in a small minority of the patient, that's a yes. I absolutely agree with you that. And wonderful to have people coming from Maharashtra, because there's another one, Dr. Sushma Dugad. Role of formoterol versus salmeterol. What is your opinion? $1 million question. She is trying to divide us between GSK and AstraZeneca or whatever that thing is. So what's your answer, faculty?
So, sir, if you say formoterol and salmeterol, they both are very good as a maintenance drugs. But when
Absolutely.
you take it as a rescue, that is what we say as the smart therapy. In that case, formoterol, the studies have shown, and it's also the pharmacokinetics, the onset of action is very faster. So
Yeah.
in that case, it can be used as a rescue as well as a maintenance therapy. But with the salmeterol, the problem is it can be used only as a maintenance, and for the rescue, it becomes a problematic.
Absolutely, absolutely. Beautifully said. I think the message is very clear. Anybody else wants to add anything to this? But the idea of immediate onset of action is so important. And in fact, that's why vilanterol is also doing so well, because the onset of action is within minutes. With budesonide, we had done this, and we had done a head-to-head comparison between formoterol and salbutamol, and we did it around 200 patients plus in a controlled trial in 2005, and we published this published in the sense presented it in the European Respiratory Congress, and we found that the bronchodilation which was initiated by formoterol was not only equal but even better and faster. And of course, it was longer sustained. There was no question about it. So if I have a drug which is as quick in onset, within 1 minute we could document, within 5 minutes and 30 minutes. So we did 1 minute, 5 minutes, and 30 minutes after the bronchodilation, and the bronchodilation which was caused by 5 minutes with salbutamol and budesonide was similar. So salbutamol and formoterol was similar in action or quantum. There was no difference between them. And at 30 minutes, in fact, because there was a budesonide also in that preparation, it was acting much better. So because budesonide kicks in as an inhaled corticosteroid as a synergistic action to formoterol. So over a period of time, by 30 minutes, we were having much better bronchodilation as well as more stable patient at 30 minutes. So I think this was one of the simple messages we could convey to majority of our population over a period of time. And therefore, I think we stopped doing bronchodilator reversibility studies with conventional salbutamol, though it is still recommended, but at the same time, we don't do it because we simply don't want our patients to get exposed to SABA. Because I'll tell you a story, and then you can end with the story each as concluding remarks. But the story was one of my patients who was staying in Dubai used to go with a bag full of salbutamol inhalers. And how many inhalers? 250 inhalers in a year, Sabas. 250 inhalers a year. And he was consuming all of them religiously for 9 years. And all I had to do was put him onto formoterol budesonide, and then he was using 12 inhalers a year, and that's it. That was the end of the story. So the change was so dramatic that half his bag would be having only inhalers, and now only 12 inhalers for a year. And he is working in Dubai, hardworking man. So he was an active asthmatic, and he needed long-acting beta-2 agonist and inhaled corticosteroid in appropriate dosage. And he was all he was getting was SABA. So SABA abuse is a reality in this world. Even today, it is possibly a reality. And therefore, I think one of the most contraindicated drugs, in my opinion, in asthma or obstructive airway disease is SABA mono usage. I'm not saying that about SABA in emergency situations. That's a different story. So with that, I invite each of one of you to give concluding remarks, and I think we'll end this session. So we'll start with the first speaker, which was Dr. Jyoti. So your concluding remarks. Now, you don't have to speak about what I said, so it could be anything.
So you have rightly said everything about the drugs which are contraindicated in OAD. Nothing is like contraindicated absolutely, but there are relative contraindication, as I told regarding the beta blockers, because the cardiovascular comorbidities are very common in obstructive airway disease. So we don't hesitate to start beta blocker. If there is a need of beta blockers, we can start with the beta blockers, because we have a very highly cardio selective beta blockers in currently available, like bisoprolol, nebiprolol, and bisoprolol. So don't hesitate in prescribing beta blockers in patient of COPD and as well as asthma with cardiovascular diseases.
Yes. Greatly said. Prajay, we come to you because you are the second speaker.
So regarding my topic only, as I was describing about aspirin exacerbation of respiratory disease, so that topic doesn't fear you that you should not use aspirin. So before using this drug, you have to be just take a proper history where the patient has asthma history, rhinitis, polyps, and all that. Then you have to be a little careful. But that doesn't mean that you can't use aspirin, because it's a beautiful drug and a wonderful drug. If you get that symptom, then be little careful before prescribing it, or do a desensitization so that the patients can be beneficial with that particular drug.
Absolutely. Beautifully said. Absolutely wonderfully said. In fact, there is nothing like total contraindication. There is a relative contraindication, and a proper indication identification is very, very important. I'll come to Dr. Gopal Krishnan, and Pramod, you are the senior most and my closest, so I'll leave it to you in the end. So Dr. Gopal Krishnan, your thoughts.
So there's a wonderful talk by Dr. Prajay and Dr. Jyoti have covered entirely about like what are the drugs are contraindicated and relative contraindications. I conclude my session is like drugs which are contraindicated in asthma and OAD are better to avoid, like propranolol and all. Drugs with relative contraindications, use judiciously, monitor the patient's signs and symptoms, and monitor the peak expiratory flow rates, and try to look for exacerbation and treat them appropriately.
Perfect. Very beautifully said. In fact, if you really ask me, after COVID, I have started using PFR so much that I am almost 100% insistence on PFR for about a year, because India has 3 seasons. So we have to go through all the 3 seasons and we do the PFR monitoring. And PFR is one of the most sensitive tools. In fact, none of us can perform a weekly spirometry also. Forget about monthly or 3 monthly spirometry. Forget about, 3 monthly is also, it is said, but it is difficult to practice in the true sense of the word. But a person can daily do a PFR charting, and PFR can give an early clue about a drug which he is not tolerating. For example, it could be anything. It may not be a drug which is related to what we are prescribing. It could be some other drug, but he uses it for 5 days and suddenly the PFR drops for those 5 days. And the moment the drug goes off, he is back to normal. I think that's a beautiful way of looking at it, because it's cheap. It's almost, zero expense, and it's easy to execute at home. So I think, and more importantly, you get a longitudinal data. That's the important thing. Dr. Pramod, I come to you and my best friend from Indore. And once again, as you said, huge Indorean faculty, faculty as well as attendance is expected in my
Yeah,
NAPCON.
sir.
Yeah. So, and all my CCI colleagues are once again welcome to that. But Pramod, your final comments, and we'll
It
continue.
was a wonderful session, sir, because many times we are going the indications, but this is the first time the seminar which has been enlightening the drug should not be are used very cautiously into different. I think the first and all, the history is very important. What disease you are dealing with? It is not a left and right. The pregnancy woman, if it is there, it is just azithromycin is on the drug.
Yeah.
Even the patients having the levocetirizine should not be used like this way. So I think many patients of cardiovascular disease with COPD, they have to be cautiously use beta blocker. They are not absolutely contraindicated, as Dr. Jyoti has pointed out very nicely. In some time, the NSIDs which are left and right using, which may not having the insight into whether the nasal polyposis is so high and that it may be culprit form. They may have the rheumatoid arthritis sometimes using dosages, the NSIDs in a higher amount. So I think use of peak flow meter and the drug dosages, interactions, and what are this should be very cautiously, genuinely sitting, and it takes a time consuming, but once you get a right track, the patient will be the benefited long life. Thanks.
Yeah, I think if I'm not wrong, I'm told that there are 1,000+ people who are logged in at this point in time. Wonderful and great attendance. Once again, we had a wonderful session. I thank Dr. Jyoti, Dr. Prajay, Dr. Gopal Krishnan, and Dr. Pramod. From the bottom of my heart, I welcome you to Pune NAPCON January 23rd to 26th with a great gusto, and the CCI family will be there with me, I'm sure about it. With that, I conclude today's session with a great deal of joy and pride and satisfaction. We have done reasonable justice to this funny topic, funny sounding topic, but at the same time, very important one. Thank you. Thank you very much to everybody.
Thank you, sir.
Thank you.
Thank you
Thank
very
you,
much,
sir.
sir.
Good night.
Thank you.
Thank you.